Corneal rings, arcus senilis. This is deposition of lipid in peripheral cornea and central sclera. Deposits start inferiorly, then superiorly and becomes annular. Extreme anterior corneal periphery appears free of lipid. Lipid deposits begin at decimates and Bowman's membranes, forming two apex to apex triangles. Arcus juvenilis. This is arcus at an age less than 40 years. In males, it may be significant for coronary heart disease. May occur in type 2 and 3 hyperlipoproteinemia. Corneal lipid deposition also occurs in hyperlipidemia syndromes, lecithin cholesterol acyltransferase deficiency, fish eye disease, and Tanguy disease. Kayser-Fleischer ring, or Wilson's hepatolenticular degeneration, copper deposition in decimates membrane. Corneal copper occurs in cases of calculosis, increased copper transport proteins in multiple myeloma and lung tumors. Inflammatory conditions, acute keratitis and corneal ulcerations. Corneal ulcers, destruction of corneal tissue including epithelium, Bowman's membrane, and stroma. Invasion of inflammatory cells results in scarring in non-ulcerative keratitis. Corneal ulcers may be central or peripheral corneal ulcers. Bacterial keratitis. Organisms include gram-positive organisms as Staphylococcus aureus, pneumococcus, Streptococcus pneumoniae, and Pseudomonas aeruginosa, contact lens wearers. Gram-negative rods, Escherichia coli, Proteus species, Klebsiella pneumonia. Predisposing factors of bacterial keratitis: epithelial defects as in trauma, severe debilitating conditions as in immunosuppression and steroid intake. Superinfection secondary to a primary viral keratitis, and abusive contact lens wear. The following occurs in bacterial keratitis: bacterial adhesion to corneal epithelium. Staph aureus binds to collagen using adhesin. Pseudomonas aeruginosa binds to exposed molecular receptors on injured epithelial cells. Bacterial proliferation and invasion of stroma. Cytokines and chemokines release trigger inflammatory response. Polymorph nuclear leukocytes migrate from limbal vessels by diaperesis, collect between lamellae, resulting in basophilic necrosis and loss of stroma. Hypopion ulcer. This is a form of corneal ulcer associated with deep stromal involvement, severe iridocyclitis, hypopion, which is pus in the anterior chamber, site at the bottom of the anterior chamber by the effect of gravity. It originates from an inflamed iris from toxins diffusion. Its color is yellowish and is composed of fibrin with iris pigment and inflammatory cells, polymorph nuclear leukocytes. The organisms responsible for hypopion ulcer include pneumococci in 80% of cases with typical hypopion ulcer, Morax liqueficans, Staphylococci, Streptococci, and fungi. In hypopion ulcer, the epithelium shows a sharp demarcation line. The ulcer tends to spread deep in corneal stroma, where dense stromal suppurative inflammation, necrosis, edema, and posterior abscess occur, centrally, resulting in central abscess. Differences between advancing and healing edges. Advancing edge occurs towards the center. It is undermined, epithelialized with vascularization and dense infiltration, while the healing edge occurs towards the edge. It is sloping, non-epithelialized, with no vascularization and little infiltration. Fungal keratitis is corneal infection by fungi. It constitutes 5 to 10% of infectious keratitis. Organisms include filamentous fungi as Cephalosporium, Fusarium, and Mucorales species. Yeast as Candida albicans and Aspergillus. It has a delayed onset, 1 to 2 weeks. Predisposing factors of fungal keratitis: trauma, vegetative material forming an epithelial defect, severe debilitating conditions as immunosuppression and topical steroids, corneal surgery as keratoplasty and keratotomy, chronic keratitis by herpes simplex or vernal conjunctivitis. In fungal keratitis there is central dry ulcer, which may be granulomatous or chronic non-granulomatous, gray-white corneal infiltrate with feathery margins, satellite lesions around the central ulcer, Fungal keratitis invade anterior chamber, inducing hypopyon. There are fungal hyphae that permeate stroma, located at the periphery and depth of the ulcer, and thus missed in superficial scraping. It is best stained with gomori methenamine silver or PAS techniques. Mycobacterial keratitis, caused by Mycobacterium tuberculosis, atypical mycobacterial infections, and leprosy. Mycobacterium tuberculosis keratitis, chronic keratitis due to affection by acid-fast TB bacilli. Organism stains with Ziehl-Neelsen stain. Viral keratitis. It is caused by herpes simplex type 1 or herpes zoster. Herpes simplex keratitis. This is the most common infectious keratitis leading to visual loss in USA and Europe. Herpes simplex virus type 1 causes orofacial and ocular infection, while herpes simplex virus type 2 is responsible for genital infection and neonatal infection. Herpes simplex virus 1 infection. Primary infection involves skin and mucous membranes. Herpes simplex virus type 1 spreads along sensory branches of trigeminal nerve to be latent in sensory ganglia. Recurrent ocular infection. Herpes simplex virus type 1 is associated with frequent recurrence due to latent virus in Gasserian, ciliary, or sphingopalatine ganglia. Recurrence is more frequent in HIV infection. Primary infection. Unilateral in vesicular blepharitis, follicular conjunctivitis, and dendritic epithelial keratitis. Recurrent ocular infection. In blepharoconjunctivitis, superficial ulcerative keratitis, which is dendritic keratitis with or without stromal involvement. Primary epithelial infection causes punctate epithelial erosions and dendritic ulcer. Dendritic ulcer forms along corneal nerves, shows arborizing pattern. It has terminal bulbs which represent lack of intercellular mucin binding protein. Epithelium around the ulcer is swollen. Dendritic ulcer shows Liebschultz or type A Cowdrey intranuclear acidophilic inclusion bodies, which is a round mass with peri-inclusion halo on Giemsa stain. Multinucleated giant cells cultures are positive in 75% of cases. Geographic epithelial keratitis. Steroid use results in coalescence and expansion of dendritic ulcer. Wesley ring. Immune reaction with polymorph nuclear leukocytes and plasma cells around the central lesion with a clear tissue in between. Another lesion is the satellite lesion. Viral keratitis. Non-necrotizing keratitis. Herpetic interstitial keratitis shows unifocal or multifocal stromal haze, no epithelial ulcers, and vascularization. Stromal disciform keratitis. This is inflammation of corneal lamellae followed by chronic slow healing and vascularization. Stromal edema with T lymphocytes and plasma cells infiltration. There is epithelial edema and keratic precipitates. Stromal leukoma is related to steroid abuse that suppresses normal immune response. Necrotizing herpetic keratitis. Rare, suppurative corneal inflammation. It could be perforating or non-perforating with stromal thinning and is matter seal. Herpetic endotheliitis. This is granulomatous reaction to Descemet's membrane. Epithelioid and giant cells accumulate at Descemet's membrane. Herpetic iridocyclitis could be granulomatous or non-granulomatous. Uveitis with or without necrotizing keratitis. Trabeculitis occur resulting in elevated intraocular pressure. Metaherpetic keratitis. Interstitial stromal keratitis with chronic epithelial defect. It is caused by neurotrophic mechanism, immune reactivation, and devitalized corneal stroma. Differential diagnosis of dendritiform corneal epithelial lesions. Herpes simplex virus, adenovirus, varicella zoster virus, Epstein-Barr virus, neurotrophic keratopathy, which could be post-herpetic or diabetic. Drug toxicity, as thiomerzal, antivirals, beta blockers, and systemic medications. Acanthamoeba keratitis and epithelial deposits as iron lines. Acanthamoeba keratitis is protozoal infection of the cornea with acanthamoeba. The organism exists in fresh water, soil, and tissues in two forms. ectocyst, which is a mononucleated motile trophozoite, and endocyst, which is a dormant cyst. Organism resists freezing, desiccation, standard chlorination of water supply, and antibacterial agents by cyst formation. Predisposing factors of acanthamoeba keratitis: soft contact lens wearers and bacterial contaminated solutions. Acanthamoeba can flourish in gram-negative bacilli. Homemade saline: swimming or hot tubs while wearing contact lenses. Disruption of corneal epithelium. Pathology of acanthamoeba keratitis. Early changes include epithelial involvement by patchy epithelial irregularity, multifocal epithelial ulceration, showing the dendritic pattern. Painful progressive stromal keratitis, iritis with hypopyon. Late changes: annular infiltrate, ring ulcer, which is almost pathognomonic. The ring-shaped infiltrate is caused by polymorph nuclear leukocytes interaction with intact organism, antigen, or byproduct of infection. Central stroma within the ring is infiltrated with clear lacunae of relative sparing. Radial perineuritis due to perineural inflammatory cell aggregation. Stroma shows amoebic cysts, trophozoites, moderate necrosis, and loss of keratocytes. Corneal perforation. Diagnosis of acanthamoeba keratitis. Calcofluor white fluorescent dye aids in detecting cysts. Corneal biopsy using a 1 to 2 mm strifine may be necessary. Confocal microscopy and culture on blood agar. Chronic keratitis. Interstitial stromal keratitis. Herpes simplex disciform keratitis. Cultures are negative. Transmission electron microscopy shows virus particles in stroma. Primarily, it is an immune reaction to persistent viral antigen. Scarring, lymphocytes, and plasma cells are present. Granulomatous reaction to Descemet's membrane is present. It is suggestive of herpes, but also seen in other entities. Lutic syphilis, old lutic interstitial keratitis. Bilateral condition in congenital syphilis, first or second decade. Rarely seen in acquired syphilis, where it is unilateral and sectoral. Systemic findings include partial deafness, Hutchinson's teeth, prominent frontal eminence, saddle-shaped nose. Acute salmon patch, secondary to corneal vascularization. Pathology of interstitial keratitis. Early changes include stromal edema without ulceration, inflammatory lymphocytic infiltrate. Late changes: Bowman's membrane loss, faint nebulous corneal opacity, deep ghost vessels in the posterior 1/3 of the stroma, thickening of Descemet's membrane, massive with formation of hyalinized bridges and strands. Differential diagnosis of interstitial keratitis. Infectious causes: viral infection by herpes zoster, varicella zoster, mumps, and measles. Chlamydia trachomatis lymphogranuloma venereum. Bacterial infection by Mycobacterium tuberculosis or Mycobacterium leprae. Parasitic infection as in Lyme disease and leishmaniasis. Helminthic infection as in onchocerciasis. Non-infectious causes: Cogan syndrome, non-lutic interstitial keratitis with deafness. Systemic diseases: sarcoidosis, Hodgkin's disease, mycosis fungoides. Foreign bodies as insect hairs, ophthalmia nodosa, and plant material. Drugs: systemic gold, arsenic, allergic reaction. Peripheral ulcers: immune-mediated peripheral keratitis, marginal corneal infiltrates, and catarrhal ulcers. These are small foci of superficial peripheral ulceration and infiltration that represents a hypersensitivity reaction to staphylococcal blepharitis, atopy, and immune vasculitis. Lymphocytes and plasma cells are present with normal intervening corneal tissue. Ring ulcers: coalescence of multiple peripheral ulcers leads to formation of a ring ulcer at corneal periphery. It is associated with Staphylococcus aureus and less commonly trachoma. Autoimmune collagen vascular diseases like lupus, periarthritis nodosa, Wegener granulomatosis, and rheumatoid arthritis. There is affection of superficial stromal layers with neutrophils, plasma cells, and lymphocytes, with rare perforation. occlusive vasculitis of arteries.
Morin's ulcer, chronic serpiginous ulcer, chronic progressive painful idiopathic peripheral corneal ulceration, unilateral disease of middle-aged individuals. In Africa, severe bilateral disease in young. Parasitic infection may trigger immune reaction.
Morin's ulcer is an immune disorder with positive HLA class II antigens. There is ischemic necrosis and excessive limbal collagenase activity. Morin's ulcer is an excavating ulcer in limbal area that extends circumferentially, centrally with an overhanging advancing margin, and peripherally towards the sclera. Lymphocytes and plasma cells infiltrate cornea deep with extensive necrosis, thickening of corneal stroma, and epithelium at the margin. Terrien's marginal degeneration. This is a bilateral, slowly progressive, non-inflammatory thinning of peripheral cornea. It affects males in the age of 10 to 30 years and associated with vernal keratoconjunctivitis. In Terrien's marginal degeneration, limbal depression begins superiorly, secondary to stromal thinning. The epithelium is intact. There is Bowman's and superficial stromal loss, vascularization, occasional lymphocytes, plasma cells, and histiocytes. Corneal pannus. Pannus is tissue ingrowth from the limbus onto the peripheral cornea. The infiltration is superficial, between corneal epithelium and Bowman's layer. Inflammatory pannus. This is peripheral ingrowth of fibrovascular membrane beneath epithelium. It is caused by ulcerative or non-ulcerative keratoconjunctivitis. Bowman's membrane is destroyed. Healing occurs by fibrosis. Lipid plaques are deposited within in long-standing cases. Degenerative pannus is fibrous tissue interposed between base of epithelium and Bowman's membrane. It occurs in chronically edematous corneas, as in chronic glaucoma, bullous keratopathy, and trauma. Bowman's membrane is intact.